Welcome, everybody, and thank you so much for joining us this evening for this ROS webinar co-hosted by LifeNet Health and Infirmary Health. We are pleased to have you join us to learn more about the ROS procedure, including a clinical overview, surgical technique, and patient outcomes. And so my name is Dr. Elena Gianulis. I'm the Senior Medical Science Liaison with LifeNet Health, a nonprofit global leader in regenerative medicine and life sciences. I'm pleased to have Dr. Kareem Bedeir and Dr. Peter Pluscht III, cardiothoracic and vascular surgeons with Infirmary Health, both joining me this evening as guest presenters on their clinical experience performing the ROS procedure. Dr. Bedeir is a board-certified and fellowship-trained cardiothoracic surgeon with Cardiothoracic and Vascular Surgical Associates. He is triple board certified by the American Board of Surgery, the American Board of Surgical Critical Care, and the American Board of Cardiothoracic Surgery. Dr. Bedeir has been widely published in several peer-reviewed journals. Dr. Pluscht is a board-certified and fellowship-trained cardiothoracic surgeon, also with Cardiothoracic and Vascular Surgical Associates. He is a fellow of the American College of Surgeons and a member of the Society of Thoracic Surgeons, Southern Thoracic Surgical Association, Medical Association of the State of Alabama, and the Medical Society of Mobile County. Both Dr. Pluscht and Dr. Bedeir have a high volume practice with a special interest in complex aortic and valve surgery. Additionally, the Cardiothoracic and Vascular Surgical Associates are the market share leaders for cardiovascular, thoracic, and vascular surgery in the Alabama Gulf Coast region. And so this is the general overview of what we will be presenting tonight. I'll first give a very brief introduction to LifeNet Health, and then I'll get into the burden of aortic valve disease and discuss the current treatment options, which will lead us to the introduction of the ROS procedure and the rationale for why surgeons are choosing to use the ROS procedure and why it works. And then I will turn the presentation over to Drs. Bedeir and Pluscht, who will share their experience performing the ROS procedure, and we will conclude with a question and answer panel discussion with the surgeons. And so with that, throughout the webinar, there is a question and answer section within the WebEx. And so I ask you to please submit any questions you may have for Drs. Bedeir and Dr. Pluscht. And when we get to that question and answer segment, we will do our best to answer as many of those questions as possible. And so LifeNet Health is a nonprofit global leader in regenerative medicine with a mission of saving lives, restoring health, and giving hope. We fulfill our life-changing mission by focusing our efforts in three core areas. First, LifeNet Health's organ procurement organization saves more than 600 lives annually through transplantation. Second, LifeNet Health Biologics provides more than 1 million tissue implants globally each year for the use in a vast range of surgical procedures, including the ROS procedure, as well as several other surgical procedures beyond the ROS procedure. And then finally, LifeNet Health Life Sciences offers innovative human cell and tissue-based solutions for biomedical researchers developing the next generation of therapies. And through it all, we remain steadfast in our commitment to honor the donors and donor families whose selfless generosity makes our work possible. And so now turning our attention to the ROS procedure, the focus of this webinar this evening, beginning with a brief background of the procedure. Valvular heart disease is a global burden affecting an estimated more than 74 million people around the world. Rheumatic heart disease is the most prevalent of the valvular heart diseases globally. However, in the developed world, aortic valve stenotic disease, also known as AVSD, predominates, with the highest rates being reported in North America, Europe, and Australasia, and the prevalence of which increases with increasing age. Furthermore, deaths caused by valvular heart disease are most commonly attributed to aortic valve disease, accounting for approximately 61% of all valvular heart disease deaths. So it is a global burden of very large proportions. And so how then do surgeons seek to treat patients with aortic valve disease? In terms of treatment options, there are a number of options surgeons can choose from for the repair or replacement of a diseased aortic valve. First of which is mechanical valves. These valves are associated with long-term durability, making them a very popular choice. However, they also have that requirement of needing lifelong anticoagulation treatment for the patient, and particularly for younger patients, this can be a somewhat burdensome additional treatment. Bioprosthetic valves, these are grafts or valves that are derived from porcine or bovine tissue and are treated to reduce the risk of rejection because it is a xenograft tissue. However, there have been reports that they are associated with high risk of structural valve degeneration over time. Homografts or allografts, these are grafts that are derived from donated human tissue, and they have an inherent resistance to infection, making them an ideal option for patients who have infective endocarditis. However, they are associated with a risk of valve calcification that can increase over time. And then finally, transaortic valve replacement or transaortic valve implantation. This is a less invasive procedure in which a new valve is inserted into the aorta without removing the damaged valve. And so that less invasive approach can be appealing. However, it is associated reportedly with low durability and therefore is not always the most ideal option, particularly for younger patients. And so with these limitations, they're still seeking an appropriate treatment choice for patients with aortic valve disease. And so this leads us to the Ross procedure as an alternative option versus those valve replacement options that we discussed previously. So what is the Ross procedure? Well, first, if a surgeon is making the choice to treat the patient with a Ross procedure, what they would do in the surgical technique is first identify the aortic and pulmonary valves and essentially inspect them for their functionality and degree of disease of the aortic valve. Once they've been inspected and identified and the surgeon makes the decision to proceed with the Ross procedure, then the diseased aortic valve is removed, and you can see that there, and then the patient's own pulmonary valve, which is known as an autograft, is excised from its current site, and then it is trimmed in size to match the aortic valve position. After being trimmed in size to match the aortic position, it is then placed in the aortic position to replace the aortic valve, and then a pulmonary homograft or allograft is used to replace the pulmonary valve, essentially reconstructing the right ventricular outflow tract. The Ross procedure was first introduced and performed by Dr. Donald Nixon Ross, a renowned and accomplished cardiovascular surgeon from London, in 1967 based on earlier experimental work conducted in dogs. Early on, there was a great deal of interest in the procedure. However, over time, the popularity waned primarily due to the complexity of the procedure and the belief that the procedure creates a essentially two-valve disease requiring the reconstruction of both the aortic and pulmonic positions. However, in more recent years, over the last decade essentially, there has been a renewed interest in the procedure, largely attributable to the increased clinical evidence supporting the long-term survival and valve durability in patients who have had the Ross procedure performed, as well as evolution and advancements in the surgical technique. And Dr. Bedeir is going to go into both of these aspects more deeply in his presentation. And so with this growing supporting clinical evidence, why is the Ross procedure believed to work? What is the rationale? The first factor to consider is that the aortic valve is replaced with a, quote, living autologous substitute, which is purported to have better adaptive remodeling, both anatomically and hemodynamically. And with that, there has been reported to have restored hemodynamics in the aortic position to physiologic levels, both at rest and during exercise. Furthermore, the hemodynamics in the pulmonary position are different than that in the aortic position, having lower and less transvalvular pressure, and therefore the homograft is better able to withstand these lower pressures. Secondly, the Ross procedure, using both an autograft in the aortic position and a homograft in the pulmonary position, avoids the need for lifelong anticoagulation treatment, as is required for many alternative valve options, as was summarized earlier. And so because of this, these two factors really support the use and performance of the Ross procedure. And so to summarize this first portion of the webinar, the Ross procedure is a specialized technique to treat aortic valve disease using a pulmonary autograft to replace the diseased aortic valve, and then a pulmonary homograft to then repair and reconstruct the right ventricular outflow tract. Though it is technically challenging, requiring the reconstruction of two valve positions, it is associated with excellent clinical outcomes, which again, Dr. Bedeir will elaborate on, including long-term survival, which is comparable to the general population, as well as high freedom from reintervention on both valve positions. And then additionally, because of the use of an autograft and a homograft, it alleviates the need for lifelong anticoagulation treatment. And so collectively, it is an ideal option for younger patients, particularly those with an active lifestyle. And so now I'll turn the presentation over to Dr. Bedeir and Dr. Pluscht, who will share their experience performing the Ross procedure, followed by a question and answer panel discussion. And so as I said previously, please, if you have questions for Dr. Bedeir and Dr. Pluscht, place them in the Q&A section within the WebEx, and we will do our best when we get to that panel discussion to answer as many of those as possible that are submitted. And so Dr. Bedeir, I turn it to you now.
Thank you, Elena. Thank you for the introduction. Can you hear me well?
Yes, we do.
All right, let me share my screen. All right, I'm going to go through what the data tells us about the Ross procedure and whether it should be considered in the right patient. And then I'm going to go into some technical details about how to do it with good outcomes. So these are the options that Elena have alluded to, and the theoretical advantages of the Ross being a living valve under a high stress environment, is able to grow, able to adapt, and then avoids all the drawbacks of prosthetic valves, whether it's bleeding, endocarditis, anticoagulation. But the question for me today is whether the data supports that. The Ross has been first introduced in 1967, and it always begs the question is, why has it not taken off in adults? The answer is because it's technically nuanced operation. It's pretty complex. And in the context of what is believed to be an equally effective, much less complex alternative, which is a straightforward surgical aortic valve. And on top of that is some early discouraging data. So this is an STS analysis from all North American centers published in 2014. This included 3,000 patients, all adults. And what it showed is that the Ross had significantly worse outcomes than surgical AVR. And the mortality was higher, it had more re-explorations for bleeding and more renal dysfunctions. And that has led to what we see as a trend as a peak in the Ross in 1997, 98, and then to a nadir around 2010 to less than 1% of total AVRs in North America. Trying to go forward with the slides. Okay. So if we look in the fine print in this study, we find that there were 231 North American centers in this analysis. 81% of those centers only performed 4 Rosses per year or less. This is pretty bad for the majority of centers, and probably it's argued that if a center performs that little number of Rosses, they should not be performing it. Even worse, 216 surgeons, 91% performed less than 5 Rosses, not per year, but over the 17-year period of the study. Obviously, with this kind of a technical operation, 5 Rosses over 17 years, that 1 Ross every more than 3 years, 91% of surgeons. So this may explain why those outcomes were not so good. Along the same lines, this is another STS database analysis that looked at any kind of root surgery, not necessarily complex root surgery, but any kind of root surgery. And the median for sites in North America was 2 roots per year. Probably all those sites that are performing 2 roots per year should not be performing the Ross. Lastly was a question related to durability. This study is widely coded. It's from Rotterdam, Netherlands. It included 94 patients, and 44% at 13 years required a reoperation of the autograft. Those 94 patients were over 17 years, which is 5 cases per year. And it is very crucial to know that most of these patients were, the primary pathology was pure AI, and the root dilatation started while they're still in the hospital, immediately post-operatively. For that reason comes the importance of reinforcement. Now we do the ROS a little bit different, and there are various methods to reinforce the ROS to prevent this autograft dilatation, especially in people with severe AI or discrepancy between the pulmonary and the aortic annulus. Pros and cons of different modalities of reinforcement we can discuss later. So now the context that I was talking about of the impression that there's a simpler option with great outcomes is not exactly true. And this study published in New England Journal of Medicine really begs to differ. This looked at California population, 45,000 patients getting mechanical or biological prosthesis, and the outcome was pretty dismal, 15-year mortality of 24 to 40% in patients between 45 to 64 years of age. And if you see the curves there, it really doesn't matter if it's mechanical, biological. It's just those people in real world data don't do as good as we think they do. Another study basically telling us the same message is a pretty large study, including 23,000 surgical aortic valves. And these curves are the patients that got an AVR versus the general population. And you see that they do not regain their normal life expectancy after an AVR. And that loss of life is bigger the younger the patient is, which is pretty crucial here. So the data really tells us that prosthetic aortic valves, whether biological or mechanical, are really not curative, and they're palliative procedure and do not restore life expectancy. The question is the ROS any better? And to look at that, we know that looking at the STS database, there are a lot of centers that should not be doing the ROS that have done the ROSs. And really, we believe the theory is that they made the outcomes look not so good in that 2014 STS database analysis. If you look at higher volume centers who published their data, this is from University of Toronto. This is a propensity matched cohort looking at ROS versus mechanical valve, 208 versus 208. They found, first of all, the operative mortality was pretty low, given their experience. There were significantly less strokes, less bleeding, and improved and less cardiac mortality in the ROS population. Interestingly, the freedom from reintervention at 25 years was equivalent between the ROS and a mechanical valve. We always think of mechanical valve as one and done. However, mechanical valves do get reoperated on for various reasons: endocarditis, pannus. Some people cannot tolerate anticoagulation and would ask for a change in that valve, and probably we've all operated on people like that. That plus the decent durability of the ROS make them not significantly different in various reports. Another study looking at the ROS versus mechanical valve, this one from Australia, from Dr. Skillington's group, also propensity matched, very low operative mortality on both arms. But you look in long-term follow-up, survival with the ROS is much better. And the survival is really the mother of all outcomes, regardless of anything else. At 20 years, 94% survival in the ROS arm versus 84%, and that's adjusted. Looking at comparing to tissue valves, that's another propensity matching from the University of Toronto. The ROS had lower strokes, obviously less permanent pacemaker implantation, but more importantly, significantly less reintervention, the curve on the left, and significantly improved survival compared to tissue valves. At 20 years, 25% of the tissue valve population have died, and around 9% of the ROS population have died. And these are matched groups. This is a larger propensity match analysis looking at the New York and California populations published by the group at Mount Sinai. At 15 years, the Ross had the lowest endocarditis, bleeding, and strokes, which is expected. It's just proving what we had as a theory. And reintervention of the Ross in this cohort, at least, was better than the biological valves, which we know, but it was not as good as the mechanical valve. More importantly, really, than reinterventions is the curve here. You see the mechanical or bioprosthetic survival or mortality for this curve is much higher. The two curves on the bottom are the Ross population and the matched general population who never had an AVR. And you see the Ross is the only one that restores that survival. And we're going to get to see that same curve reproduced in various populations. This is a really important study, because it's really the only randomized control study that looked at the Ross. This was published in 2010 at The Lancet from Professor Magda Yaqub's group and Dr. Hamamsi when he was back in England. Population was a British population, 18 to 69 years of age. They followed these patients for 13 years. The freedom from autograft reintervention was 99%. Another reason this study is pretty important is that is the survival really better because the Ross avoids the drawbacks of prosthetics, whether they're endocarditis or anticoagulation. So the homografts are very resistant to endocarditis and do not require anticoagulation. And still, you see that those curves there. The Ross restored survival to match the general population. Homograft did not. And the theory has to be is because it's a living valve in a higher stress environment capable of adapting, repairing itself, growing. So even a homograft was not as good as Ross. And then as in more recent years, and that is partly why this renaissance of the Ross that happened over the last 10 years, as more centers started publishing their higher volume centers. This is a cohort of Dr. Tyrone David, very low operative mortality at 20 years, 10% mortality. Remember, compared to 24 to 40% the New England Journal of Medicine paper, and reintervention at 20 years around 20%. Pretty good results. This is a pretty large registry from high volume European centers, 2,400 patients with a median age of 44. 5% of those patients with more than 60 years, which is interesting. 60% were bicuspid valve. Also interesting, maybe why this outcome is really good is 44% of this population were reinforced Rosses. Likely those were the ones with pure AI. Very low operative mortality. Again, freedom from any reintervention at 20 years, around 80%. And almost a quarter of the population that needed reintervention on the pulmonary homograft were done with a transcatheter technique. Again, the most important outcome is survival. You see that curve there. It is the Ross versus general population. No different. No other technique does that. This is another recent study published in JAMA Cardiology. Relatively high volume, median age is 49. Same, very low operative mortality. And these are the data we get from centers that have high experience with root surgery and have a dedication to the Ross procedure. It's not what the SDS database showed us that included centers that really should not be doing the Ross. Lastly, this was just presented in the last WATS. This is the same population from the randomized control study in the Lancet by Dr. Yaqub. This population was followed for the third decade and impressively had a 98% completeness of follow-up. The median follow-up was 24, with some patients were more than 30 years. It showed the same excellent results, and again, the same reproduced curve, which is equal to the general population. But interestingly, the operative mortality for the first reintervention after the Ross was 0%. And 10-year survival after that second reintervention was 96%. Pretty impressive data when it's done in the right center. Don't want to take longer than this. Just to conclude that we need to understand that prosthetic valves are palliative. They're not curative. And the theoretical advantages of the Ross are founded by the data. It is the only AVR solution that does restore life expectancy to the general population. Importantly, that the ROS is definitely much more complex than a simple AVR, and not everyone should be doing a ROS. There's a dedication involved, and before embarking on the ROS program, extensive aortic root expertise should be available. All right. Do you want to, should I proceed to the technical component, or do you want to take questions?
Yeah, that's exactly what I was going to ask. What technical considerations do you have for the ROS procedure? So we can move on.
I'll go through a quick video just highlighting. Can you see my screen?
Yes, we can.
All right. So this particular patient was also going to get a hemiarch and a ROS. The only reason I mentioned that is that if this clamp was going to come off, we're going to do some arch work and then reclamp. But if generally in a ROS, you want to put the clamp as high as you can, that will make your distal pulmonary anastomosis so much easier. And you're going to see that when we clamp the graft after we do the hemiarch. Here, opening the aorta as usual. The first really thing here, I want to stress that even though we're talking about the ROS is the best AVR, but an aortic valve repair that is durable is better than any AVR. So it's important for the surgeons and the attendees is to always evaluate the valve for repair if possible. In this particular case, there was just a lot of calcification and foreshortening of the leaflets. So an AVR was decided on leaflet size in the usual fashion. So as of now, I did not create the coronary buttons. The homograft is not thawed. We're not committed to a ROS yet. This can still be an AVR. So the pulmonary artery is dissected from the aortic wall with a bovie. Obviously, the pulmonary artery wall, as we all know, is very thin. Care should be taken here. The idea is just to separate it enough so that you can mobilize it and cut it. So a little technical detail here is that you see that sucker in the top of the screen. That really pulling this down towards the feet helps straighten out that PA to make the cut much easier, right proximal to the right PA takeoff. So, and this is now the PA lifted up. You have to be very, very careful with the left main and the LED coursing here. And I use a bovie. There are different ways of dissection, but you really want to hug the PA and not really be buzzing too much here. And as soon as you see this muscle here, that's really as far as you need to go. This is usually at the level of the pulmonary valve. We test the pulmonary valve, even though really the real test is intraoperative TE before surgery. Sometimes you would not be holding or lifting it up correctly, and it would leak a little bit. Of the pre-op TE is fine. What you're doing really here is looking at the leaflet integrity, making sure there's no hole in the leaflet, no major fenestrations that will give away when it's under systemic pressure. If you like, this is where we start committing to a ROS. As soon as we light the valve, the homograft now is starting to thaw, and you go with that right angle, like a few millimeters below the opposing leaflet of the pulmonary valve. You can do this with a scissor. I like to use a bovie. Most crucial here is to be a little conservative towards the right ventricle until you can get a good visualization of the pulmonary valve leaflet. If you get the pulmonary valve leaflet with the bovie, your operation is done. As you proceed laterally, you have to be very careful with the LED. And so here it's important. You go very, very thin layer. So as we know, the pulmonary valve is higher than the aortic valve. And really this first portion of the muscle is not part of the interventricular septum. The left ventricle starts lower. So that's really not interventricular. As soon as you go here, you lift that pulmonary artery up, and then take your bovie almost parallel to the ground, and really enucleate it from that plane. And that really helps you not get into those septal perforators. As you get more lateral, you have to be cognizant. Sometimes the LED is pretty close here, and you have to be careful with that. So the muscle here doesn't provide much support, so we don't leave much of it here, probably just a few millimeters below the pulmonary valve insertion site. And then you see this strip here. This is, the valve here has already been sized with a Hager dilator. And then we use this around 5 to 6 millimeter sizes above that Hager dilator to go as an external annuloplasty strip. Here confirming the cuff of muscle. Take this off, and while on the Hager, these are very superficial bites, just incorporating the fat, just to keep it in place. This is important here. Remember, many of these patients who require an AVR when they're young, they're bicuspid valves, and their commissures are likely not the normal orientation of an aortic valve. So putting marks here with the commissures of the pulmonary valve is our way of identifying where the commissures are going to be in the native aortic annulus. The right coronary button is fashioned, and it's really standard, nothing special for the Ross. It's important, like with any operation, is here to avoid injuring the coronary, is to really dissect the aorta away from the coronary, not the coronary away from the aorta. Same for the left button here being dissected. Now, there are multiple ways to really put those annular sutures. You can do it as interrupted. You can do it as mattress. You can even some surgeons even do it as a continuous. The key really is to exit the needle deep in the LVOT, and that is one of the first things, aside from the annuloplasty that we use on the autograft, that really helps put the autograft deep in the LVOT to avoid any late autograft dilatation. I usually use non-everting sutures in AVRs, but in Ross I use everting. And as you see, the needle comes out 3 to 4 millimeters below the annular level. Here, the important thing here, obviously, you go through the autograft and through the strip. The important thing really here is to be very cognizant of where the commissures on the annulus are. And this is not shown in the video, but if your pulmonary valve is pretty symmetric, you can use a tissue valve sizer to decide on the native aortic valve annulus which sutures are going to go into your autograft commissures. Or you can use those lines. I lower that graft into the LVOT and use those lines to decide where the commissures are going to be on the aortic valve annulus. Either way, you cannot distort the configuration of the autograft by those sutures. Also, not just the rotational orientation. The commissures go up and down, and if it's a bicuspid valve and those commissures on the autograft do not line up with your native aortic valve commissures, you got to not really follow the line with those sutures on the autograft. Otherwise, you're going to flatten the autograft commissure, and that's going to decrease your durability and may cause a leak from the get-go. So you really need to completely ignore your native valve annulus and respect your autograft annulus. That's the summary. It's important to make sure all the suture and none of the sutures went through the leaflets. And then we lower it and hand tie those. The autograft is much more compliant than any graft, and the left button almost always go to the mid left sinus, and those lines on the location of the commissures really help with that. This is the left coronary being reimplanted. You see here, I didn't mention that this is the hemiarch is done. This is a pretty extensive hemiarch, and you see the clamp is almost flush with the innominate artery. It's like almost at the very top of that hemiarch, and you will see why as we get to the pulmonary anastomosis. It's just this part of the operation we skipped. There's nothing really different here. The sewing the button to the homograft, obviously you need to be very careful with torquing. It's not like sewing it to hemishield graft, but it's also pretty hemostatic. It's the needle holes don't bleed on homograft, just like on autografts, just like homografts. So now this is another important step here for avoiding autograft dilatation, is that you do not want to leave too much pulmonary artery tissue above the valve apparatus. Just a few millimeters above your commissures, above your neo-sinotubular junction, just to sew to. If you leave a lot, that's going to get aneurysmal under systemic pressure. So you trim to like 3-4 millimeters above the commissures, just enough to sew to. Before you put the aorta back together, it's so much easier to put the pulmonary valve, the RVOT together with the aorta out of your way. This is just, we put lines here so that after you remove the branches, you don't get disoriented. So while the branch is still in, you identify which is the right pulmonary artery, where's the PDA, then put lines there to identify the two extremes. This is your distal anastomosis. You see how the clamp can be, if it's low, it can be very annoying, especially on that medial end of that anastomosis. This is a normal anastomosis. Obviously, like with any pulmonary artery anastomosis, you just no torquing on the needle. This can tear easily. It's also important either to lock every couple of sutures, or to just make sure that your assistant does not really follow that tight, because it's not very difficult to purse string this anastomosis. This is let's see. The proximal anastomosis, I brought it back because this suture is important. The LAD is here. Sometimes it's as close as here. And it's important with this first suture not to incorporate the fat. You can kink the LAD if you incorporate the whole layers. So just be cognizant of that. The posterior aspect, it's really try to take big bites and not very deep bites. And medially, it's just keep an eye on the tricuspid valve papillary muscles, because they can be caught. We de-air the right side, test our anastomoses and repair anything now if there's anything that needs to be repaired before the aorta is in the way. Now, this is also a crucial step. So right at the sinotubular junction of the autograft, so we try to trap the autograft really at the base with the annuloplasty strip, and then at the sinotubular junction with this interposition graft. Even if no hemiarch is being done, we always use an interposition graft at the sinotubular junction to prevent the distal end from dilating. And the sizing and the orientation of this graft is important. This is here marking the the points that were aligned with the commissures. This graft, the size is not the size of the annuloplasty strip. This is the same size of the Hickory dilator. The annuloplasty strip was about 6 millimeters larger than the dilator. And you see here that the line on the autograft is meeting the line on the hemishield. One thing we do here while we have the graft long is to put our cardio line in and give some pressure in the root. That make sure the LV is not distending. We have good root pressure. You know that aortic valve is competent, but also check hemostasis at the button and that anastomosis. Again, it's so much easier to fix it now. And then this is a standard graft-to-graft anastomosis. This is the right button. We distend the heart as usual and give cardioplegia and the right, and just see where the right button wants to lie. Most of the time, the right button goes, even though you trimmed the autograft very low, just above the sinus-tubular junction, most of the time it does lie on the autograft itself. Right here, you see it's very high up on the autograft, like the upper border of the button. The sutures will incorporate the graft-to-graft anastomosis, the autograft-to-graft anastomosis, which is fine. If the center of the button really is right on that anastomosis, you can mobilize more and go higher. Definitely don't go lower. But there have been times where the right button was reimplanted on the hemishield graft, and that was fine. And that's really with the patient decannulated and one thing I want to say about this echo, this thickening here is always there after this technique with the Ross. And it's important to be aware of that and have your team and your cardiology colleagues aware of that after the Ross, because it might be confusing. They may think it's endocarditis or other things or clot. And it's just a common finding after these. All right, thank you.
Thank you, Dr. Bedeir. That was enlightening and fascinating and very impressive to see your technique and learn as you went through the entire procedure. So thank you very much for walking through that. So now we're going to proceed to our question and answer panel discussion. And as I said before, if you have any questions, please submit them in the Q&A within the WebEx, and should be in your lower right-hand corner if you're in the app, and if you're in the browser, it should also be I believe, in the lower right-hand corner. We do have some questions that have begun to come in, so I will go ahead and proceed. This first question is actually for Dr. Pluscht. So when choosing what patient would be appropriate for the Ross procedure, who would you consider would be an ideal patient for the Ross procedure or appropriate for the Ross procedure, and who would not be and why?
Well, ideal patient is less than 50. Highly active person helps. Is very beneficial in the female population, especially in the younger female population that wants to have children and don't have to worry about anticoagulation with a metal valve. Who not to do it in is people with connective tissue disease, autoimmune disease, prior radiation, or somebody who you think the life expectancy is less than 15 years. It's not a big advantage to do this operation of those people. Between age 50 and 60, I think you've got to have a really perfect person that's active and you think is not going to, somebody you think is going to do well and live a long time. Clearly, aortic stenosis is the more favorable reason for the pathology for this. Aortic insufficiency is not as optimal, but doable, especially with some of the new techniques like Dr. Bedeir was mentioning with the wrapping the proximal portion. But I think whenever you get above 27, 30 millimeters of aortic root dilatation, that's a suboptimal situation. And if he's got severe AI, in that category, should be more directed toward aortic root repair of the aortic valve than the Ross operation. That's what I would recommend at that point. So you want a pretty close match between the pulmonary valve and the aortic annulus. You'd like that to be within 3 to 5 millimeters of each other. If it's over 5 millimeters, you're treading in dangerous water. So the people that do have severe AI and a large root, those people with the leafless work route should go to repair and not Ross. But any patient that's less than 50 and a lot of good indications, aortic stenosis, they're the ideal candidate. You agree, Kareem?
Yes, absolutely.
Excellent. Well, thank you. A second question also for Dr. Pluscht. So now that you've identified the patient, an ideal patient, less than 50, active, potentially a female, what do you want for this patient? What do you want to see for this patient post-operatively? And this, again, Dr. Pluscht, this question is directed to you.
Well, from a medical standpoint, what we want to do is control their blood pressure. We've known that first 6 to 12 months, that's very important over the long-term benefit of the operation. So we would like to keep the blood pressure under pretty tight control, but usually that's the case. Basically, they should only take a baby aspirin at that point in time. But we're encouraging people to get back into activity, do things, be active in sports, go back to work, do the things that they do. The first person I did was 21 years old, have children, lead yourself in a normal life. The last patient I did is a very interesting guy. He is responsible for taking the first test flight of all Airbus jets that are being made. And we're going to be in the process of getting his FFA requirements back for him after the 6-month time frame. We're going to do a few more echoes on him than normal because of the FFA, but his echo so far looks great. We want to do echoes. I'd like to do an echo before they leave the hospital. I like to do an echo at 3 months and then an echo yearly. But we very much encourage people to get back into what they want to live their life normal. That's the purpose of this operation.
Mm-hmm. That's wonderful. And just as you said, that's the purpose of the operation, to get patients back to their normal lifestyles and back to their regular activity. We have a third question, and this question is actually directed to Dr. Bedeir. If you have an eligible patient, or to the audience who has an eligible patient, who should the audience member send that patient to? What are the qualifications that the audience member should be looking for in a surgeon for his or her patient?
Well, the answer is not very straightforward. I mean, with this Ross renaissance and Ross getting more traction in the last decade, there have been experts talking about what number cutoff is okay to say that this center is a center of excellence for Ross, and they have quoted 10 to 15 cases a year. This year, I just looked, we're probably going to be doing 23 or 24 this year, which is well over what, and some people think even 15 is too much. But more importantly, in the Ross, this doesn't mean that people will start Ross programs as it gets more popular. And so where to start is a center that has a lot of familiarity with complex root surgery. that is a prerequisite for embarking on the Ross. And this data, if you have a patient, you just ask how much complex routes are they doing? Bowel sparing routes? Are they doing a lot of Bentals? I also looked at the data. Last year we did 45 routes other than the Ross. So this makes sense to do the Rosses. We looked at the slide that I presented earlier that the median root surgery per site in North America is 2 a year. Obviously, these centers should not be doing Rosses, and that is a median. So 50% of the centers do less than that. And I think that study showed that 95% do less than 16 a year, not Rosses, any kind of root surgery. So it is root expertise is important, and it's helpful to know what kind of Ross experience and outcomes the site has.
Excellent. Great advice. And as a follow-up to that and somewhat related, another question, and I'll direct this to you, Dr. Bedeir, and then Dr. Pluscht, if you have any additional to add. What role do cardiologists play in buying into the procedure or recommending the procedure, and how did or can that collaboration start?
Well, it's interesting if like 90% of my slides were published in JACC, Circulation, and Lancet. These are not surgical journals. Mm-hmm. So it's our duty to educate people about the data. It has Ross scared some people away from early outcomes. We have learned from the mistakes of the past, and we know that these outcomes are not what the outcomes of experienced people show. Really, it's on us to educate all our referring doctors, and they will probably educate the patients, and that will be the way.
Mm-hmm. Well, I think to add on that, I know how Kareem and myself have gotten. My first Ross experience started when I was a resident. And then after about 3 years, I got into practice. It was in the late 90s, early 2000s. The Ross operation was waxing, okay? And then about 2005, newer tissue valves came out, and everybody thought that was going to be the greatest thing alive, but it turned out not to be. So we're seeing this second or third or fourth or fifth. It's really many up and downs. But I think the reason we're seeing this renaissance now, as Kareem used the word earlier, was cardiologists. We have a very close working relationship with them. They're seeing a lot of patients now for TAVR valves. And everybody knows that a TAVR valve is not, it's safe use sternotomy, but it's not the perfect thing for every patient. It's like anything else. It's got its place. So, and my experience with cardiologists I work real carefully with, they know that the Ross operation is a very good outcome and the longevity of it, because it's in their literature. It's been in their literature more than it's been in the surgical literature. So we've sort of collaborated on when and how, and mainly we have together identified which is the best patient. People less than 60 years old getting a TAVR valve, that's really got to be a special patient. You're not expecting that patient to have a long lifespan, et cetera, for maybe whatever disease. So I think that's how we've gotten back into doing it, and how we're looking at what selection is. The TAVR valve has made us rethink it, and I think that's where we are.
Very interesting. And just as you said, it's a collaboration. You work very closely hand in hand with these cardiologists to make these decisions. Another question that came in, and I'll direct this first to Dr. Pluscht and then Dr. Bedeir if you want to add on that as well. I know Dr. Bedeir reviewed and mentioned in his presentation some approaches to prevent aortic dilatation, but can you kind of revisit those, elaborate them? What can be done to prevent aortic dilatation in the Ross procedure?
Well, if you have a small root from aortic stenosis, it's probably not so important to put some type of band, but I've just made the stipulation in my second go round, where really near the last half of my first go round with it, I put some type of support there. It just makes sense. I learned that really from the aortic homograph procedure, and it just correlates the same. So I initially started out with autologous pericardium, and I have used core matrix material. But to me, as I've thought about it and performed it, the HemiShield graft makes the best long-term support, both for me to figure out in the operating room what size that I want it to be. That's the method that I have taken for that reason. I think it's the best fixed result, both to help the surgeon perform the operation and throughout its tenure. I think it's going to give the most reliable outcome.
Dr. Bedeir, do you have anything to add as well?
No, it's just, I mean, again, there are different techniques, and we don't know whether one technique is better than the others. There's theoretical, well, I mean, but the two important spots to support it is the sinotubular junction and the basal ring, and it's crucial in patients with pure AI or where discrepancy in the annuli, like Dr. Pluscht has mentioned. There's Dr. Yakub has a huge experience with this, and he uses other techniques other than the HemiShield. He uses this loose jacket technique. He uses just all interrupted sutures and pushes the homograft all the way down. But there's almost consensus that there has to be some support to the basal ring. Again, whether the way I showed it, whether as an outside of the whole aortic root with a dissection, like with the valve sparing root from the outside. But you know, just do it. If it's pure AI, if you don't do some form of support, that's a recipe for failure. There is a way where they put the autograft inside a HemiShield Valsalva graft. This is probably the only guaranteed way to avoid dilatation. But again, a theoretical price that you pay is that you lose the dynamic benefit of the normal movement within the cardiac cycle that you have with an autograft. That you just like completely froze it with that Valsalva graft. So it's not clear which method of support is the best, but we know that no support in AI is pretty bad.
I want to just add something that's because Kareem is a young surgeon, but I'm unfortunately one of the senior guys, and I've seen a little bit more. One thing I want to mention: when I was in my training, we did not support the proximal annulus. We did not support it, and I've actually reoperated on some of those people from my training site. But interestingly, the first one I did not support it either, and that's the only one that I've ever had to reoperate on for late complication. And she was a female, had 3 children, and I had to reoperate on her at 26 years. And it was because of AI. And I've always wondered if I would have had support, if it would still be going. So I can't answer that.
Right.
But I know
Sorry.
Go on.
They also argue that reoperation at 26 years is not really a failure.
That's
Like
what I was going to say.
Really good 26 years without anticoagulation and had kids, and we cannot look at that as a failure.
Maybe.
I would agree. Well, it's still very remarkable results, and thank you both for your time. And because it is 7 o'clock now, it's 7:01. We are going to wrap up, but I thank you both, Dr. Bedeir and Dr. Pluscht, for joining us tonight and sharing your experience and some of the technical aspects and your insights into performing the Ross procedure over your career. And it's been highly informational and highly educational, and so we very much appreciate it. Any additional questions that have come in, we'll try to see if we can direct them to you later on and have them answered. To those who have joined us tonight, thank you so much for joining. You will see shortly A link will appear on your screen, and in case you get a notification, a warning notification on this, it is a safe site. This is our Ross procedure landing page that you can visit for more information, more education on the Ross procedure, and we'll have this presentation webinar recording up on that site as well. So thank you all for joining, and one last again, thank you, Dr. Bedeir and Dr. Pluscht, for your insights and your perspective.
Thank you.
Thank you.